Fine.
Yeah, yeah,
So
fine.
lessons learned from my roadblock cases. Okay. And that's the disclaimer. So this is a patient who had come to me. This is many years back. This is a story which is in 2008. So all the modern surgical techniques and modern drugs and all were not available. We did have Lucentis, but other things were not available. This patient was a 64 years female who was diabetic for 16 years, thalassemia minor, well controlled metabolically. She had blurred vision in both eyes. He had NPDR with macular edema, had undergone multiple injections of Avastin and supplements tripod. And she had come to me, and her son was a major criminal lawyer. So when she came to me, this was the picture, and we at that time had an opto-view OCT, no angio-OCT for those days. But anyway, she had thickened both right and left macula with spongy and cystoid macular edema, no vitromacular traction. And I decided that I would go ahead and give Lucentis. Patient had not received Lucentis before. So we gave her Lucentis, but actually it did not make too much of a difference. And then we started trying to understand. So this patient was well controlled metabolically, but her hemoglobin was 9.8 and did not increase. I consulted the physician, and he told us that the patient has to live with this hemoglobin, and the hemoglobin can vary anything from about 8 to 9.8. She has never gone beyond 9.8. So we know that thalassemias are the commonest single gene disorders. They are autosomal recessive. They can cause defects in the color vision, abnormal dark adaptation. They can produce an isolated cataractal changes. And she did not have any of these things. She did not have increased vessel tortuosity or a picture which is related to thalassemia, which is a pseudoxanthoma elasticum, a picture with angioid streaks and leopard skin appearance, blue orange. But the patient had macular edema and blurred vision. That was the only feature of this thing which we thought was diabetic macular edema. She did not even have, she had not got any transfusions. She had not been put on any chelating agents, obviously because the hemoglobin is not high, and physicians were unwilling to give her any blood transfusion. Now we know that supplemental oxygen improves diabetic macular edema, so we discussed with her whether you would have nasal oxygen connected every day at house so that you could increase your blood oxygen level, but she refused. She said, no, I can't do that. You do whatever you want, but I'm not going to sit at home and have oxygen going into me. So please remember, this is almost 11 years back. I was working as a lone practitioner, not being guided by any institutional backing. I looked up the literature and talked to many retina friends from across the globe. People were that time not sure that vitrectomy could be done in a non-tractional case for diabetic macular edema. Patient had already received Subtin on steroids, so there was no point injecting too many steroids, and the only option was to give an IVTA. But well, I asked myself, is there traction? So there was, or is the ERM, is the PVD? How is the ILM? Is there significant ischemia? How is the peripheral retina? So these are the questions which I wanted to ask, and I found that there was no demonstrable traction on the OCT or clinically. There was no epithetic membrane, and there was no PVD, obviously. ILM did not appear to be thickened, at least in the OCT, and peripheral ischemia was not there. We went to the literature, and it's been shown that if this was in animal eyes where one eye is vitrectomized and the other eye is not vitrectomized, and branch venous occlusion is created in one eye. In both the eyes, the eye where the branch venous occlusion is created in the vitrectomized eyes does better than the eye which has got vitreous in it. So whenever we do a vitrectomy, we know that there are fluid currents, which means they bring in oxygen from the periphery to the area which is seen. So this is what happens either because of laser or because of vitrectomy. You end up having more oxygen supply to the macular area. And since there was no demonstrable ischemia, additional laser was ruled out. We talked to the patient's family and decided to go in for a vitrectomy. So this is what happened after vitrectomy. Her macular thickness decreased dramatically. It was less by about 200 odd microns, and we operated the other eye. Her visual acuity improved in the right eye from 6 by 60 to 6 by 24, in the left eye from 636 to 6 by 18. And she has now been on intermittent follow-up. Right now, she's in the US. The whole family has actually become connected with us as family friends. Right now, she's in the US, and I've not seen her for a few years. But whenever I get a chance, I will probably like to do an annual history for her. So here is there was another patient who was a 60 years old male, diabetic for 10 years, hypertensive, blurred vision. Patient had CKD, splenomegaly. On examination, patient had pancytopenia, was worked up for bone marrow. There was hypercellular, gastroduodenoscopy was done, malaria antigen and Kala-Azar antibody was done because they wanted to find out why the patient has lowered hemoglobin. This was the picture. Patient had a macular edema, had been lasered, uh, underwent cataract surgery in the center, and had received multiple injections of intravitreal eccentrics. So the patient would respond to eccentrics, and subsequently, what happened was that there came a point where patient said that I can't keep on having injections. We could not do any additional laser. So we had an option. I discussed with the physician whether a splenectomy is indicated or a renal transplant is indicated. We lost the patient for follow-up for a little while, but eventually patient underwent a renal transplant. He came back to us, and since last 8 years, patient has not required an intravitreal centric for any antiviral. So the spleen size had reduced, the anemia had improved, macula became flat, and did not require any additional anti-VEGF. So the take home from both these cases is that anemia must be treated in any case of macular edema. Vitrectomy helps in macular oxygenation even in a non-tractional diabetic macular edema without IL-8, and one can judiciously use anti-VEGF and other parameters need to be handled. Right? Now, this is a convention. This is a case which I wanted to share because of the COVID times. We know that we have been bothered about COVID with intravitreal injections, and the question is, does it really matter if the injection is delayed in a diabetic patient? So here is a female who had a visual acuity of 6 by 12. She came to us in Jan 2020. This is a clinical picture, the angio-OCT done on 21st of January. And on 1st February, she received intravitreal eccentrics in the left eye. This is the picture of the left eye before and after. Visual acuity had improved 6.6 post-injection when she came to us on the 6th of February 2020. After that, COVID came in. The patient was not able to come, and she did not come to us for 6 months. But the patient was communicating on the phone. Patient had maintained a good metabolic control. So this is the right eye when the patient came back to us this was on 6th February, where the patient came back to us in August. The visual acuity had deteriorated. You can see the OCT here, the macular edema had increased. There were cystic spaces present here. In the left eye also, the visual acuity had reduced from 6.6 to 6.12 parts. So almost 6 months had passed away. But then we talked to the patient and decided that we will go ahead and inject. And so the patient underwent intravitreal injections at at different periods of time. This was on 17th of October. After the injection, patient's visual acuity had improved. Then subsequently in March, patient received the fourth intravitreal injection, March 2021. And then after that injection, went ahead with the cataract surgery. And now in April, she is not in a follow-up. This is what the OCT is. And she's doing well. The visual acuity is 6. And same thing happened with the left eye, where again, after the fourth intravitreal injection, she had a cataract surgery in the left eye. And again in April 2021. So both eyes did well, though there was a gap of almost about 6-7 months despite, because of COVID. Despite that, in diabetes, even if there's a little delay because of the COVID situation, the problems related to the diabetic macular edema are not so significant that they are side effects. This is so this is another patient who presented. There's a 61-year male, type 1 diabetic. He had a hemoglobin A1C of 10. And this is the picture. It's very difficult to interpret this macula, but the patient received 3 injections of monthly Mellitus. Visual acuity improved to 612. And then the patient was lost for follow-up, came back after 6 months. Metabolic control was okay. The hemoglobin A1C was 8.6. Otherwise, was metabolically stable. But we got a wide field angiography done, and the patient had this picture had been lasered before. So this patient underwent additional PRP. Subsequent to this, the edema became stable. Visual acuity was 6/9 and has been followed up with no further injection. So basically, the take home from this was that we must not only look at the diabetic macular edema, look at the periphery. In case additional laser is required, that should be lasered. Otherwise, we'll keep injecting these patients who actually would benefit from additional interventions done to the periphery. For this, the wide field angiography. Okay, so I just finish the last thing. So this is a 58-year-old obese female who was diabetic for 18 years, who was taking lasered, also glaucomatous, had received intravitreal injections, both Avastin, Lucentis, and subsequent Ozurdex. This is the picture in the right eye, this is the picture in the left eye, and this is, she came to us when Ozurdex was not available. So she has all the biomarkers of the OCT suggesting that she would need a steroid, but she is glaucomatous and Ozurdex is not available. And so what next? Should we give an IVT? No, because she's glaucomatous, the pressures are going to go up. Subterenal strikeout, again the pressures are going to go up. Should we do a vitrectomy? I'm not sure. So epimembrane is there. And clear-side biomedical suprachoroidal triamcinolone is not available. So we went ahead, and I'll just show you what I did. This is a small device which I have made for suprachoroidal injection of triamcinolone, where the 30 gauge needle is used. Triamcinolone is injected into the suprachoroidal space. Usually, for initial patients, we were actually measuring the scleral thickness and deciding where to inject. So this is the picture. This is pre-SKITA, suprachoroidal injection of triamcinolone. This was on the 14th day, 34th day, and 70th day. Similarly, in the left eye, she did well. So this is the comparison, and this is overall the picture the patient did pretty well. Thank you for your kind attention. I hope I have not overshot my time too much.
Thank you, Dr. Ajay. I mean, lovely cases, very challenging cases, all of them, especially the ones, the initial two, the one with the thalassemia and the patient with the transplant. It's not easy to, it is a brave call to take, do that, surgery. And we do know that, oxygenation can help the macular edema.